So the last time, this was what we did, right? We ended with this one. We said emergency situation. Remember, we were doing things on chest tubes, emergency situations, and what we have to do, right? Tube dislodgement. We have to apply occlusive dressing on 3 sides. Then when there is a system break, we have to put the tube. You know, the chest tube itself. When there's a breakage, you have to dip the tube in a sterile water, right? The last time I explained why it is so. You know, it will prevent air from getting into the tube, then into the chest, right? But when there is any air trapped within the chest, it can get out of the chest through the tube, then through the water, then it comes out, right? That is why it is very compulsory for you to keep a bowl of sterile water close to someone with a chest tube. Okay, it's a requirement. So let us take note. Then when there is no drainage, okay, when there is no drainage, when you have a patient and there is no drainage from the chest tube or from the chest, okay, and the patient is in distress, you have to check for what? For blockage. Sometimes there could be blockages in the tube, right? Or I mean, it could be that the tube is kinked. So you have to make sure that the tube is not kinked, there are no blockages, and you have to make sure that the collection device, okay, or the system itself is below the heart level so that it can facilitate actual drainage, right? And when there is sudden increase in the drainage, you have to notify your provider immediately. So look at this one. But I think we talked about this one too, right? I think we have something on the next page. I'll show you very soon. When there is hemorrhage, okay, infection, air leak. The last time we talked about cardiac tamponade, right? That is what triad. What triad did we talk about? That it's linked to cardiac tamponade.
Bex.
Who remembers? Bex triad, right? Yeah. So do you know
The Bex
the
triad.
components of Bex triad? We mentioned it the last time. Who can tell us very fast?
Hypertension.
Are you sure hypertension? Is it hypotension or hypertension?
Hypertension.
It is low blood pressure, please. So take notes, okay? Yeah, so it is hypotension. That's low blood pressure.
Yeah.
Low blood
Muffled
pressure,
heart
right?
sounds.
Muffled
Yeah.
heart sounds. So another name for muffled heart sound is what? If like, let's say if you don't see, someone said that, if you don't see muffled heart sounds and you see some other thing, remember the last time I told you the NCLEX can use the other names. So if you are stuck to muffled heart sound and you don't see muffled heart sound, what should you notice that is the same as muffled heart sound?
Distant heart sounds.
Distant heart sounds. Good. Distant heart sound. So either you see distant heart sound or muffled heart sound. It's the same thing. So it's like there's a fluid around the heart when it beats. Okay, when you listen to that sound, it looks like the heart is immersed in the fluid whilst it's beating. So that's how you hear that sound. Please, the Beck's triad that you are saying. Let me see if I can write it here. BECK apostrophe S. So this is the Beck's triad you are talking about. Okay, that it is linked to cardiac tamponade. Remember, this morning we talked about what? How many triads? Plus Beck triads. How many triads have we talked about this morning? Or this evening?
Some of us were in here.
Oh.
we've thought about what Veco's triad, right?
Yes.
And we've thought about Vex triad. Okay, good.
Yes.
So that is it. And what's the last one? We've made mention of hypotension. Please, hypotension, everybody knows that is the same as what? Decreased blood volume, right? Sorry, decreased
Distended
blood
neck
pressure.
vein.
Okay. Yeah, so the last one is what? The distended neck vein. If you don't see the distended neck vein, what is the other thing you can see or you're likely to see?
Muffled. Jugular
Another
vein
name,
distension.
good, jugular vein or jugular vein distension. Okay. So take note, either you see distended neck veins or jugular vein distension, they can use them interchangeably. The next one is muffled heart sound, muffled, M-U-F-F-L-E-D, muffled heart sounds or distant heart sounds. And I've told you, it looks like the heart has been immersed in some water as you auscultate, okay, when the heart is beating. So that's how you hear the sound. And the last one is hypotension. That's low blood pressure. Okay, so that is extra yard. To tell you what's happening is what cardiac tamponade. Okay. All right, then if you have tension pneumothorax too, so all these things could mean that what there could be a complication of the chest tube in situ, right? So all these are complications of the chest tube in situ. So let us take note. Let us take note very, very well. All right. Now, some English tips. Continuous babbling. Whenever, remember the last time I told you, when you see chest tube questions and there is no, when you see chest tube questions and there is no suction attached to it, please, any continuous babbling is abnormal. I'm repeating that. So listen to me very well. If you see any chest tube question and there is no suction, like they don't mention that it's connected to a suction wall, any continuous babbling is a problem. It means air leak. But whenever there is a chest tube and it's connected to a suction, a gentle continuous babbling is normal. It is not a problem. I'll repeat that side again. When you have a chest tube question and it's connected, they tell you it's connected to a suction wall. A continuous babbling or a gentle continuous babbling is a normal thing. And in that case, if it doesn't continue to even babble, that is a problem. In that suction, in compartment. Do you understand that side? I think I've said it over and over sometime. Oh, all right. Then, so remember this one, because we have not mentioned any suction, so that is the clue, okay? If there is no suction and they just tell you chest tube, don't add the suction in your mind. If they want to let you know that it's connected to a suction, they will tell you it's connected to a suction. So don't always add it in your mind. Okay. When you hear just chest tube, it is chest tube. There is no suction. Unless they tell you it's connected to a suction wall. So with this one, you see when you see tidalin, okay, tidalin, it's normal. So as you see the person breathing in and breathing out, you see air movement, okay. Yes, so that is this. That is the tidalin. It's not a continuous one. It's like it moves with the person's breathing. Okay. And please, whatever it takes, when you get English questions, whatever it takes, try not to even clamp the chest tube at all. Okay? Try not to clamp the chest tube at all. So when you get questions that tries to tell you that clamp chest tube, please don't be careful when you're choosing that. Don't you are not likely to get it correct when you choose clamping of the chest tube because of the complication it can come with. Okay. But if let's say there are issues and you need time, you can so this is the word briefly and only for a short time. Some other archives will even tell you sometimes only with prescription. Okay. So some will even tell you only with prescription. But please, most of the time, do not clamp chest tubes. And when there is sudden stop in drainage, that could mean danger. Most of the times, for chest tubes, when the issues are resolved, okay, when the issue is resolved, sometimes you would not see any other drainage because the issue has been resolved. Okay. And most of the times, every 24, as soon as chest tube is placed, chest x-ray is taken to confirm placement. Right after that, before even the chest tube, there's chest x-ray to confirm there is fluid or air accumulation. After the chest tube insertion, they will do a repeat chest x-ray to see if the chest tube is in place, is in the right place. And mostly after 24 hours, they will do a repeat chest x-ray to see whether it has resolved or it would need an adjustment. Okay, that is what is mostly done. And when the issue has resolved, per the chest x-ray, the physician will now recommend the chest tube to be removed. Any question on this slide? Okay. Now, so this is one thing about pediatrics. Okay, let us take notes. And I think it runs even for all. Remember, for adults, when you get a chest tube question with a drainage, and you have more than 100 mils per hour, it's an issue. More than 100 mils drainage per hour, that is an issue. Okay. I think we spoke about it not long ago. Now look at for pediatrics, everything is per weight based. Okay, everything is calculated with weight based. So this is the weight: 3 mils per kg per hour for 3 hours. Okay, or when you have between 5 to 10 mils per kg in 1 hour, that is a red flag. It means that drainage is too much. Okay, so we can give an example. Let's say you have a 20 kg child. You have a 20 kg child. This child goes for a procedure and has chest tube in place. And let's say within 3 hours, the child gives you 60 mils. Or no, let me say the child gives you about let's say 80 mils. Okay, for the first 3 hours, the child gives you 80 mils. Is it within normal? Within 3 hours, so 3 hours, the child gives you 80 mils. Is it within normal or it's abnormal?
It's too much.
Abnormal.
Okay, so let me explain this so that it can be tricky. Let me explain it so that you understand it well. So, you see, for this one, we are saying when you have it happening, okay, for 3 hours. So let's say if you have 3 mils per kg per hour, okay, for 3 hours. Or so I mean, wait, let us strike an example with this one, then we'll come to this one finally. So let us use my 20 kg. You have a 20 kg kid, right? Giving you let's say 50 mils in 1 hour of chest tube drainage in 1 hour. Is it normal or abnormal?
Per hour, 50 ml is supposed to be 60.
20 kg. Is it normal or
It's
abnormal?
not normal. It's abnormal. In the
It's abnormal.
kids, I think it's too much.
It's normal.
Are you sure?
It's normal. It should be 60, but
Are
this
you
is
sure?
50.
So
It's
so I'm
normal.
saying that. So wait, hold on. I'm saying the kid is what 20 kg, right? So 20 kg
Yes,
multiplied by 10 is what?
200.
20 kg multiplied by 10 is what?
It's 200. So it's
200.
normal.
Is 200. So I said if the child is giving you 50 mils in 1 hour, is it normal or abnormal?
It's normal.
It's normal. Yes, it's normal. Okay, it's normal. So that is how you calculate for the case, right? And um normally, okay, normally this is
Just
like a
join.
general calculation for case. Kindly raise up your hand if you want to talk, okay? This is just a general calculation for pedics, okay? But please, generally, let me see if I can see it here. Mr. Stephanie, you can ask your question. Mr. Stephanie, you can ask your question.
Sir, please, I just joined, so I wanted to know what you were talking about. I was having challenges. I've now been able to
Your hand
join.
was up, that's why.
Yes, please.
We are talking
I just
about
wanted to know what we are talking about, please.
chest tubes, okay? Chest tubes and drainages.
Okay.
I want to show
Okay.
you something. Yeah, I think it's here. Okay, when we first spoke about this whole thing. So look at this one. I'm going to circle it so that you can see here. Okay. So sudden increase in drainage. That is if you most of the times this is what you are likely to find. Okay. So irrespective of anything, if you see any drainage more than 100 mils in 1 hour, whether for an adult or for a kid, please, it's a cause for alarm. Okay. It's a cause for alarm. And most of the times, if it happens in about let's say for 3 consecutive hours, it means there's an issue. I mean that one don't hold it. Just inform your healthcare provider. Yeah, Sister Jane.
Please, with this point you just made, I want to find out. So we just calculated and we said that if a child is 20 kg with drainage of so 50, we used 50 mils. But then in natural fact, if you calculate, then 200 mils per hour is normal per the child's weight.
Yeah. So that is why.
So with the point is, I
Okay.
think it's contradictory, and I'm not getting it.
Okay. Yeah. So I understand you. Let me explain. Let me explain it this way. So let us use 5 to also calculate and see. Okay. This is the general thing when I mean this is the general thing you will find out there. Okay. So I think most of the times we want to, in order to prevent harm, okay, we don't want to even cross to up to this 10 mils. Okay, so what I would say is that, let's say if you use the first boundary, which is 5, if the child is 20 kg and you use 5, right? Times 5, you're going to get what? 100, right? You're going to get 100. So if you are having 100 or more, okay, in the first 1 hour, sorry, per hour, that is an issue. But it shouldn't continue for 3 hours. Okay. Sometimes you can have it just happening only once or maybe twice, then it comes back to normal. Okay, so let us take it this way. When you have more than 100 mils per hour, continuing for 3 hours, that is a cause for danger. Okay, but I'm trying to link it with questions I've seen before so that when you see questions of such nature, you can know, because some questions are very tricky. Okay, so please, just that's why I showed you that first page, right? Whenever you see anything like more than 100 mils per hour, don't even consider it to be normal. If anything, it should be about up to 100 or less. If it's more than that, don't consider it to be normal per hour. Okay, Mr. Jane, you want to come again?
Yes, I have a question. So
Okay,
the current page we are right now, you've given two
two
I don't know
formulas.
what to call it. Yes, two formulas. So the first one says 3 mils per kg per hour for 3 hours. So I want to find out, under normal circumstance, which one are we supposed to go with?
Okay,
Because you
so
see, the second one, when you calculate either ways with a 20 kg, you will get 100 mils, which indicates
okay,
that, or it depends on the child's weight.
yeah. So it depends on the child. This one even goes for an adult. Okay, an adult and like a child who will fall within the 100. Okay, why I'm saying that is, let's say if the child is 7 kg, what you'll be getting, you can't use this 100 scale for the 7 kg child. So let's say if the child is 7 kg, this one will apply. Okay. So let's say if the child is 7 kg, 3 times 7 is what? 21, right? So if the child is having 21 mils per hour and it continues for 3 hours, you have to tell your healthcare provider. Okay. Let's say 8 kg, or let's say 10, let me use 10 kg too. Okay. If the child is 10 kg and the child has a chest tube, so 3 times 10 is what? 30, right? So if the child is having 30 mils per hour for 3 hours, that is also a cause for concern. But let's use the let me use even a higher you can get pedics or pediatric children, or let's say pediatric population of maybe 30 kg. So let's say this 30 kg pedics population, or let's say a child with 30 kg. When you multiply it with this one, or let me say 35, something that you get more than 100. Okay, let us take it to up to 100. That is what I want to say. If no matter the kg that you are multiplying with, the cutoff point should not be more than 100 per hour, even though this one is there. But for questions I've seen, generally, drainages should not be more than 100 mils per hour. Do you understand what I'm trying to say, Mr. Jane?
Yes, please. So
Uh-huh.
both are red flags, right? They are not
Yeah,
normal. Both
yeah,
are
they
red
are not
flags.
normal. Yeah,
Okay.
they are red flags. that means the person is losing more fluid than, even for an adult, okay, if any fluid, let's say the person has ascites or maybe a very bad pleural effusion, and you want to remove fluids from the pleural space, or if it's maybe that, like generally, okay, per medicine, it's recommended that you should not remove more than 1 liter within a day. So if, let's say, estimatedly the patient has maybe 5 liters of fluid per ultrasound, you have to remove it slowly, like gradually. And I nurse this patient. I've seen this a patient where a doctor even removed 4 liters at once before. But those are, doctors can do things within their scope, and they have things to also manage. I've seen this before though, but please, per standard. And with regards to your exam, so if you are here and you've seen 4 liters of fluid removed at once from a patient before, doctors, it's within their scope to do that, and they give orders at any time to manage blood pressures if they are falling, or they have ways to hold on to that, okay, or to help resolve issues. But per standard, and with regards to our exams, 1 liter per day, like not more than 1 liter should go out of a patient within a day. So chest tube too, not more than 100 mils per hour. Okay. And I think most drainages too. Someone raised their
Sir,
hand.
please, how many
I
how
made
many
I made the
meals is
person.
recommended per hour?
So not more than 100 mils per hour.
And I'm asking about how many meals is recommended within the hour.
You can't say it's 90 or but if it's anything below 100, it's fine. So it could be 80, it could be 90, it could be 99, it could be whichever. Okay. Yes, but it shouldn't be more than.
Okay.
So this, you have to take note of the abnormality, the cutoff point. It is like BMP, where BMP still should not cross 100, right? BMP should not
Okay.
cross
Yeah.
100. So if you know about this, anything below 100 is okay for you. Okay.
Okay. Okay.
Jacob, your hand is up.
Yes, please. I want clarification with the two formulas given. The first one, 3 mils per kilogram per hour. And then the second one, 5 to 10 mils per kilogram in an hour. Is it that the first one is the minimum volume for concern and the second one is the maximum volume for concern, or how is the difference? Because I'm not getting the clear cut point. Thank you.
Okay. Um. All right. Let me take other questions too. Ajay, your hand is up. I'll answer you. Okay, Jacob. Mm-hmm.
Please, I just realized something that both are coming with a specific length of time. So
Mm-hmm.
if
Oh, you are
at
trying to
least
answer him, eh?
it's just a realization I just made. I was
Okay.
also
Okay.
contemplating, but
Mm-hmm.
I just realized that there are time frames to it. So probably when the question is posed, we should look at the time frame they are giving to give us an idea which formula we should go for.
Yes. Yes. So that is it. So thank you for realizing that. But let me also clarify things if maybe some of us are still having issues with it. This formula, right? Let me see. I'm trying to clean my board. Okay, let me do this. Please take note whether the person is an adult or a pediatric patient. So I should exceed 100 mils per hour. I hope that one is clear to everyone, right? So this one, let us take note. So that's our first point here. Okay. All right. So if, let's say, the person is a child, okay, or a kid, this one is giving us an idea in 3 hours, okay, in 3 consecutive hours. And this one is giving us an idea within an hour. So depending on the question. All right. So if, let's say, the child is, let's say, let me use which figure should I use? Someone should give me a figure, any raw figure. Which one should I use?
Let's use 35.
Okay, so if, let's say, the child is 35 kg, okay, 35 kg. Now, 35 kg multiplied by 3 is what?
That will be 105.
100 and what?
105.
105. So when you have this, okay, for 4 hours, let's say you have 100 and, sorry, for 3 hours, okay, when you have this happening for most of the time, just one, even up to 150 or 200 happening just once, I mean, it will be a cause for no concern. Okay. Let's say, I just want to make a reference. Let's say you are treating someone with hypertension, and the target is that you make the patient stay below 140 systolic. If, let's say, for one blood pressure check, patient went to 160 and later came back to 135 or 140, it's a cause for no concern. No doctor will do anything about this. Okay. But let's say if the patient continuously remain in 160 for about 3 hours, the person would need treatment. It means it's sustaining. Okay. That is why sometimes even when we check blood pressures and whether we have hypotension or hypertension, we even recheck and wait for some time to recheck to see whether it's a true definition of what's happening. Okay. So we don't things like this, you don't like hasten treatment, right? You just have to make sure that what is happening is persistent. Okay, or it's let's say persistent before you try to do something about it. So if, let's say, you have once this one happening once, it's not a cause for concern. But if it happens for about 3 continuous hours, then something has to be done. Okay. All right. Then this one is within 1 hour. Okay. So if let's say, let us use the same 35 here. If you use 35, multiply 35 by 5, what do you get?
175.
175. Okay. So you see, 175. So you see, we are saying 5 to 10. 5 to 10. So, remember we are saying it's red flag. So even from its lowest boundary within this range, it's even a red flag already. Okay. And if you should use the 10, it will be what, 350. Okay, which is already above the boundary. Okay, but it's just a range that they normally state. So if you have this drainage within 1 hour, it's a cause for concern. So these are the red flags. Are we there? Hussein, your hand is up.
Yes, please.
So
But
was it Adam? Adam, was it Adam who was the question? Were you the one? Hussein, were you the one who
No,
asked the first question?
no, no, for me, I just raised my hand.
Yes. Okay, well, it was Jacob. Jacob, are you
so
okay?
Jacob. Yes, please.
Uh-huh, okay. Okay, so Hussein, let's go.
Okay, thank you, boss. So unfortunately, I was finding it difficult to join as well. But then when I joined, I was following keenly, and I realized that you used some example where you calculated to get somewhere 200, and I heard something like it is normal, it is good. So I was really confused that if the 200 is normal, then why are we also saying that maybe we shouldn't get more than 100?
No, we didn't say the 200 is normal. Remember, these ones are red flags. They are look at the topics. I mean the topic here. You're saying
Okay,
this is a red flag. So this one, I think at first I used 20. So the 20 times 10 that I did and I had 200 is still a red flag because all these are red flags.
okay, okay. Thank you
So
so
I
much.
didn't say they are normal. Yeah. You understand?
Uh, Okay, I understand. Thank you.
Okay. All right. So we are saying this can indicate that there is either hemorrhage or there is risk of what? Cardiac tamponade. Adoma, your hand is up.
Um, Thank you. Please, I would want to know the weight. Is it the patient's normal weight or what's the weight that we multiply by 3? Is it the patient's weight, normal weight that we are going to multiply by 3?
Yeah, so when you say 3 mils per kg, it means 3 mils per the patient's weight. I mean, which is times three. I mean, times the patient's weight. So if the patient is, let's say, 20 kg, it's 3 times 20 per hour.
Um, okay, so the patient's weight is, I mean, going to remain constant. So I was thinking that me, for instance, that I weigh 70 is going to be 70 throughout. So all the time you are going to multiply by 3. So
You that
it's
you are
always
70,
going to
if
be
you're
a
an
red
adult,
flag.
This one
remember,
is for
Uh,
pediatrics. So
sorry,
pediatrics.
sorry to cut you short. Remember, I said,
Sorry.
whether you are an adult or
Yeah.
you are pediatrics, we don't encourage it to be more than 100. So you that you are 70, whether you are 70, you are 60 kg, you are whichever, you shouldn't cross 100. Do you get that point too? And mostly, those are the chest tube drainage questions you
Um,
are likely to get. You shouldn't cross 100 drainage per hour, like 100 mils per hour. Okay. But if you are using pediatric weights, and if you're using, especially if you have a small weight like 7, remember I use 7 kg. If you are using a weight like 7 kg, 7 kg would never reach up to 100 mils. But it doesn't mean that 7 kg patients should reach up to 100 mils before you know there is a complication. So that is where you can use a formula like this or this. Okay. So this one is like if you want to know for 3 hours, it's three if the patient is 7 kg at the weight. 7 times 3 is what 21. So it means if the 7 kg child has 21 mils drainage every hour continuously for 3 hours, it's a cause for concern. That is what we are saying. Or if that 7 kg child, 7 times 5 is what 35. Or if the 7 kg child has 35 mils of drainage in 1 hour, it's also a cause for concern. So that is what we are talking about here. Adwa, do you understand now? So you see this one, in all these cases, you don't have to wait for, they will never reach 100 per hour, but it doesn't mean that they are not suffering because you have a smaller weight. So that is why you can use this formula to calculate for the pediatrics. But if you have a child, let's say 13, 14 years, some of them can weigh higher. Okay. Please, even so, when you have this higher weight and adult, the cutoff point is like it shouldn't cross 100. I think this is much clearer, right? Are we okay?
okay. Yes, yes, sir.
All right.
So please, but when if the patient is 70 kg, when we calculate, the drainage will be more than the 100.
Yes, and
Meaning
I
we
just said
shouldn't drain more than 100. So
yes.
if we
So it means it's
calculate
an
by 3,
abnormality.
okay.
These things we've stated here, we are not saying they are normal. Oh. These things are used to calculate for abnormalities, red
I
flags.
understand, but I'm
Uh-huh.
asking, sir. I'm
Uh-huh.
asking that if the patient weighs about maybe 60 kg and we
Mm-hmm.
multiply by 5, it will
Mm-hmm.
be more than the 100 in an hour.
Mm-hmm. Which is already abnormal, right?
Okay. So we shouldn't drain more than the 100.
Yes, 100 is a cutoff point. Even if the patient weighs more,
Okay.
it shouldn't cross 100. Yes.
Well,
Okay.
sorry, Claudia, please just
Okay.
clarification. Maybe it may help all of us.
Okay.
So, the general rule is, irrespective of either pedics or adults, we shouldn't drain more than 100 mils per hour a patient. If you see that it's a red flag, you raise alarm, irrespective of the weight or the age, if I'm correct.
Sorry, I was talking. I didn't know I was muted. Yeah, so that is correct. It shouldn't cross 100 no matter what. Okay.
Okay, thank you so
Yeah,
much.
yeah, you're welcome. Are we all clear? Okay. Let's look at this one too quickly. We've thought about patent ductus arteriosus for some time, right? Um, do you know that patent actually when the baby, uh, when the baby is in, or how should I even put this? When a child is in the mother's womb, the baby has a patent ductus arteriosus, which is very normal. I think we are all aware of this, right? The blood bypasses the lungs, right? So that the lungs are not matured and the baby is not breathing in the mother's womb, like taking oxygen directly, right? Every oxygen that the baby is taking is from the mother and all of that. Yeah. So the ductus arteriosus, okay, it stays open and it's as a result of prostaglandins, okay. It's as a result of prostaglandins that keeps it open, right? Normally, within few days after birth, it should close. Normally, within few days after birth, it should close. When it doesn't close, that is where it becomes an issue. Okay. When it doesn't close, that's where it becomes an issue. So something came in mind. Let me say this here. That is why when you are pregnant, it's one of the reasons why we advise you don't take in NSAIDs. Okay. NSAIDs, NSAIDs like they block prostaglandins or they inhibit prostaglandins. You know that. So when you are pregnant and you take, or like let's say any pregnant person or a pregnant woman takes in NSAIDs, it means the patient is reducing. I keep on saying patient. It means the pregnant mother is reducing the prostaglandins in her. And when prostaglandins are reduced in the baby, it is going to make what the ductus arteriosus, that pull to close up. And that can lead to a lot of complications, right? Especially, I think within this second to third trimester, yeah, I think after 24 weeks or so, or maybe after 20 weeks or so, yeah, especially around that time. Okay, so it's very, very important that they do not take NSAIDs. Complications like this, heart failure, pulmonary hypertension, and the rest, the child can have it even whilst in the womb. Okay, so I'm saying it because of the management here. We'll come to this one. Okay, the endometers. So failure of ductus arteriosus to close that is what we diagnose I mean, if you have a child and the that cirrhosis does not close within few days, that is where we diagnose this patient of what that cirrhosis. And in this patient, you see blood flowing from the aorta to the pulmonary artery. Okay, and it is common in what premature infants. So this is how you can sense it or you can hear it. Okay, you when you auscultate their heart sounds, you're going to hear machine-like murmur, and often symptomatic. No, sorry, it's often asymptomatic, especially at their earlier phase. Take note of how you listen to the heart sound associated with patent ductus arteriosus. It's very important. Okay. All right. Now, their management. Let's say if the baby is born and after some few days it doesn't close up. If you're giving the patient some time, it doesn't close up, and we want to make it closer, we can use indomethacin. Okay. We can use indomethacin. So it is like it promote the closure. Okay. It promote the closure of the hole. Okay, so it's like indoor, okay, indoor closes the indoor, okay. You know, that is like an indoor inside door that links the I mean those two compartments, right? The aorta and the sorry, which part? Yeah, those two compartments, the aorta and the it can prevent sorry, it can lead to blood flowing from the aorta to the pulmonary artery, right? So you have, I want to show you, let me show you this diagrams. Let me use this one. So that you can see the ductus arteriosus. Let me- so the aorta and the pulmonary artery, where is it? I think we can use this one. Okay, so look at this one. Where I'm circling, let me pick up my pen so that you can see it well. So let us use this picture, okay? I think this picture will make it more clear. So that is arteriosus. So this is the connection between the pulmonary artery going to the lungs, right? Then there is the aorta, which is supposed to supply the rest of the body with oxygen and oxygenated blood. So you have a connection between the aorta and the pulmonary artery. So this is the connection, right? So this hole has to close, right? This hole has to close. So this hole was open before because the the lungs, this part is connected to the patient, I mean the baby's lungs. The lungs are not directly receiving oxygen because I mean the baby is in the mother's womb. So the blood already coming here, they are already mixed with high oxygen. Okay, so it's like already enough. I mean, it's already prepared to go into systemic circulation. That's why when it gets here, there's a connection for it to enter into the aorta, then supplies the whole body with oxygenated blood, right? But right after birth, this connection, let me clean it again. This connection has to close. Okay, that connection here has to close, right? So when you have a baby and within few days after birth, it doesn't close, that's where it becomes an issue. So like indomethacin, like I was saying, indomethacin closes the indoor. Okay, so that's maybe a trick for you to remember. Indomethacin closes this indoor. So indo closes indoor, right? Indomethacin is an NSAID anyway, and there's other NSAIDs to that can be used, like ibuprofen. Okay, sometimes even naproxen is also used, but the most popular drug used is the indomethacin. Sometimes you can see ibuprofen too, just in case. Okay, so just to let you know. So that is what we are talking about. So just to stress on the the importance of this drug, okay, or NSAIDs like ibuprofen and naproxen to help close the I mean the picture I showed you, okay, that space, that patent ductus arteriosus. Yeah. All right. So I don't think we will ever forget, right? Indomethacin to close patent ductus arteriosus. Now we are rounding up all of these things. You know, it's been a while that we talked about all of this congenital heart disease and the rest. So to round down everything we've spoken about, hypothyroidism, especially the congenital one. I mean, hypothyroidism is almost the same as that in even an adult, right? Oh, sorry. So there is lethargy, there is bradycardia, right? Left to right shunt causes what? This thing. Left to right shunt causes congestive heart failure symptoms. So we have to take note, right? Left to right shunt causes um, congestive heart failure, and they are acyanotic. I hope you remember. We said right to left shunting causes cyanosis, but left to right shunt do not cause cyanosis, right? And most of the right to left shunt, you remember the T's, the troubles, the one that we talked about, I mean, the last time we met. So even if let me see if I can show it to you. Even if you forget about cyanotic congenital heart diseases, those that start with T, even if you can't keep any name in mind, okay, if you see any congenital heart disease that starts with T, please, even if you don't know and you want to bet on it, take cyanotic congenital heart disease, because it looks like all the T's they are cyanotic heart conditions. So that is where we coined the term trouble. T means trouble, means you have trouble. And the rest are mostly cyanotic conditions, right? Okay. Then the next one, we are saying in chest tubes, you monitor for output closely. Very important. And with patent ductus arteriosus, when you auscultate, the sound you are likely to hear is a machine-like murmur. In pulmonic stenosis, it causes what? Cyanosis and it's an emergency. So this is just a rundown of what we've done, I mean, up to some time. And I have full of questions. We went through all of those things without testing ourselves. So just some few questions to ask you about all that we've gone through to see. But before that, if any of us has any question, the person can bring it out. Any question? All right. Can I get a reader to read that first? But these questions are very easy because we've talked about all of this.
A
Any reader?
newborn is diagnosed with congenital hypothyroidism. Which finding should the nurse expect? A. Hyperactivity. B. Tachycardia. C. Constipation. D. Warm, moist skin.
Mm-hmm.
Constipation.
Do we all agree?
Yes.
Yes.
Please. Constipation.
Okay.
Yes.
Okay. All right. Who doesn't agree it's constipation? Those of you who were in class, I think you remember, right? Hypothyroidism, it means you have low metabolism. Your thyroid hormones are low. Okay, so things become very, 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 very slow within you. So you have a slow GI too. Remember, hyperthyroidism causes everything to go high because you have high metabolism. So that one you're likely to get diarrhea. But with hypothyroidism, things are low, your thyroid hormones are low. So you have a slow GI. And when you have a slow GI, you get constipated. Okay. You lose energy, lethargy, and you get bradycardia. Okay. All right. The next question.
A child with a left to right shunt is assessed. Which finding is expected? A.
Mhm.
Cyanosis at rest. B. Bradycardia. C. Tachypnea. D. Decreased pulmonary blood flow.
Mm-hmm. Should you get this question on the NCLEX, what will you choose? Select your answer. Let's say you are left with only one question for you to pass or fail. Of course, failure,
Go for
God
D.
forbid.
Damn.
Okay. But you have only this question for you to maybe answer correct and pass.
D.
You choose for D, like D for dog,
Yes.
decrease
No,
pulmonary
no,
blood flow.
it's not
Tachypnea.
the kidney because D rather should be increased pulmonary because it is coming from the left to the right. So
Good. We
there's
said
going
it
to
not
be
long ago.
more
Do you
pressure
remember?
in the right ventricle. So it will be rather increased pulmonary.
Do you remember?
Yes,
Look at
that's
D.
what it
Look at
should.
option D.
Yeah.
Do you remember this one? Um, look at option like the second point here. Left to right shunt causes what? Congestive heart failure. And why is there congestive heart failure?
Flooded.
Yes, okay. And it's going to put pressure on the lungs too. Okay. So you should have I agree with our sister. You should have increased pulmonary blood flow with left to right shunts rather, not decreased blood flow. And are you sure you're going to have bradycardia?
No, tachycardia.
Tachy-
Yes,
Tachypnea.
you're going to have tachycardia.
Tachypnea. Tachypnea.
Um, like okay, so and cyanosis at rest. Left. We said it not long ago that left to right
No
shunt,
cyanosis.
no cyanosis.
No cyanosis.
So even if you don't know the answer is tachypnea, you've been able to fish out the wrong answers. You know that A, B, D, they are wrong. So what will be your best shot? You have no other option than to choose C, and that is correct because you have lots of workload happening, and you're going to breathe at a faster rate to compensate what is happening. Okay, so the answer is C. Kudos to all who had it correct. And I wish all who had it wrong in their minds come back, okay? All right. So the next one.
Which observation in an infant suggests heart failure due to a shunt? A. Sleeps through feeding. B. Sweating during feeding. C. Increased appetite. D. Weight gain.
Mm-hmm. Who wants to try?
I'll go for B.
Said B.
Good. What do you think is happening in B? Oh, some congenital heart disease, they sweat, they become cyanotic.
Text
Yeah,
tetralogy of
Tesco.
fellow.
They have
Yeah.
all those things when you are trying to feed them. Okay.
Yes.
Yeah, so yes, the answer is B. Okay. Yes, so the answer is B. So they lose weight rather, they don't gain weight. Appetite is rather decreased, not increased, because it looks like a very huge work for them when they are even eating. And of course, they sweat a lot, showing you that they are suffering, okay, or they are tiring. Then they don't sleep through feeding. No, they don't do that. So the answer is B. Are we following?
Yes.
Yes,
Yes, please.
please.
Yes.
Because you don't know when one of these questions or similar questions could be your major question somewhere. You don't know. So the answer is B. Yeah. Our next question.
A child born
Sorry, question.
post-cardiac surgery has a chest tube output of 50 mils in one.
Kindly hold on, Stephanie. Kindly hold on. I think I have two hands here. Precious first before Aduma.
Yeah, but yeah, please. The last question, even though I agree with the answer we choose and the rationale we gave, on a normal circumstance, a child who is sweating while feeding, is it not a normal finding?
Sweating
I'm
during
just,
feeding.
yes.
It's a normal sign, eh?
Yes, in
Is
some
it not
children.
a normal thing? Like, I don't know. I'm just thinking, is it not normal? Like,
Okay,
even
so
an adult.
hey, so you sweat when you are eating.
Because they are sucking
Oh,
and they are exerting energy, so sometimes they sweat.
yes,
Yes.
yes.
It's more
Yeah,
harder than it's more harder than when they are at rest.
yeah, yeah.
Mm-hmm.
So the sweating during feeding here tells you that they are suffering, like they are tiring. Okay. Or maybe I don't get your question. Are you okay?
Tajia,
Oh,
please.
yes,
I
this
also
question I have said it's okay, but what I'm saying is, should you see it somewhere else in a different
Mhm.
question, please should you take it as an issue?
Oh yeah, it's an issue, especially with regards
Yes.
to congenital heart disease. You should sweating whilst feeding is not normal.
because when you're doing pedics like this, what I learned is that during breastfeeding, I saw a question like, how will you know that the baby is like getting the feed?
Mhm.
It's and the answer was like the baby should be settled and you hear like a swallowing sound when the
Okay,
baby so the baby should be relaxed. If the
relax.
baby is relaxed, how can you sweat?
Yes. Okay. Please, it doesn't mean that when you are in a hot area and
Yeah.
the baby is sweat, that one is different. Like when everything is normal and if the baby shouldn't sweat and the baby is sweating, you will know that that is abnormal. Okay. So it's not like when you have a very hot water, sorry, hot weather, and I mean, you know that the place is very hot, and you are all sweating. That is different. Okay, and this sweating, it's not like you see the patient relax and sweating. You see that the patient is rather struggling. There is struggle. Okay, and English questions, they'll try to, even with the polish the wrong answers, they will polish it. They will not make it too awkward for you to be able to fish it out. But at least, under normal circumstance, someone feeding normally should not sweat. So that should mean that there is workload. I mean, it is like a workload for the baby. The baby is finding it a hard time to feed.
Yeah, I haven't exercised.
Yeah. Are you okay? Adma, your hand is up.
Yeah, I'm okay. Thank you.
Okay.
Thank you. Please, so my question is, is that you said a child would rather lose weight, and I would want to know the child in this situation, the child is losing weight because of the shunt or has had a heart failure
They have
because
failure to thrive because they are not getting, they have issues with oxygenation and feeding. They are not getting much of food and like, when we say failure to thrive, I hope you all understand failure to thrive. They don't feed as much as they should feed, right? Because they easily become tired, and um that is going to play a part in the weight loss. Okay, and
okay, so
oxygenation
please.
issues too. So it's all combined.
Yes, so I've solved a lot of questions, and concerning heart failure in children, they are saying that they will rather gain weight than losing weight because accumulation of fluid. Heart failure, there is anasaka fluid everywhere, so the child tends to gain weight rather than losing weight. So most of the questions that I've solved with heart failure with children, the answer is weight gain. You should expect weight gain rather than weight
Okay,
loss.
okay. So I understand you, but look at the question. It's from somewhere. Which observation in an infant suggests heart failure due to what? A shunt. Okay. So the word is due to a shunt. I know right-sided heart failure generally they gain weight because there is, I mean, fluid shifts like fluid shifts from intravascular space to what? To interstitial space or to third spaces, right? And that causes the weight gain. But this one, heart failures as a result of shunting, they don't gain weight. Okay, they don't. It's not like So this question is like, it's not actually. This heart failure is linked to the shunting, right? And the thing is, what will you see? Okay, or what, like, how are you going to see it? It's more of when you hear of congenital heart disease and shunting. I think it's so. This one is like, I don't know how to even make it simple for us to understand. When you hear of shunting, okay, and heart failure, what should come into your mind? Sleeping through feeding. Is it this one to increase appetite, right? Then weight gain. This is linked to something like they are going to have a failure, like failure to thrive. It's likely to be a test spell happening. Okay, like looking at the options here, it's likely for you to, because like they are all targeting that. There are several ways you can digest this question. There are several ways. Okay, but someone with heart failure and shunting issues, they will not be weight gain. If it's like right-sided heart failure, talking about right-sided heart failure proper, then that one will be weight gain because of three shift test basis. But this one is different. I don't know if you understand or someone can help understand, explain it well. Jane, your hand is up.
Yes,
Yes,
please.
Jane before
my
Jacob. Yeah. Mhm.
okay, my input to this is that I ever read about failure to thrive, and we should we should consider that with the question here, they are talking about an infant. An infant's age is the first year of life, and that is where failure to thrive comes in. And failure to thrive mostly comes in where the child has feeding issues or is unable to um, thrive well because of congenital diseases. And this heart failure is one of them. So they see everything or anything that is going into their body, it sees it as work. And aside that, oxygenation is a problem for them. So within this phase of life where they are not eating well, especially in the first year of life, they are likely not to gain weight. It is different from a child that has probably, it can happen later on, like until the child is 5 years. But then the first year of life, if you see children with congenital heart diseases, they are likely to be losing weight than to be gaining weight. They are likely not to be eating well, and that is one of the major challenges with them. Thank you.
Thank you very much. So let me add that before Jacob comes in. So the trick is that, please, whenever you see that there is a shunt, okay, in a question like this, please never consider weight gain. Whenever there is a shunt, the weight of the child is lost, okay, or you have weight loss, or you have decrease in weight. So that is one trick. Please, it's always like that. Okay, so that is one trick I would let you know. So this is not just a pure heart failure question. Okay, whenever you see any shunting, they are likely to have failure to thrive. So one key thing that influences our answer is the shunting. No one with a congenital heart disease that involves shunting will get weight gain. It will never happen. So that is also to add up. Yes, Jacob.
Okay, just to add a little to what our sister and you have just said about the weight loss. With the shunting issue in congenital heart disease, the child has problem with oxygenation. So when the child eats, more of the little oxygen that is reaching the vital organs and the tissues are shifted to enhance digestion. So it makes the child to even pant more for oxygen. So because of the stress, the workload in digesting the food, the child usually will not eat. Because if he eat, it is giving the child more workload. It increases the oxygen demand and make the child pant for oxygen. So because of that, the child will not like to eat. And because he's not eating, he is not able to gain weight. This is different from heart failure case. The main issue here is because of the shunt that is causing low level of oxygen in the systemic circulation. So the child will not be able to feed properly. And once he's not feeding properly, he will lose weight. The heart failure in general is when there is accumulation of fluid. In that case, the patient is expected to have weight gain. If you are not able to draw the distinction between the two cases, you be having problem with answering when they are put. Thank you.
Okay, thank you very much. Thank you very much. All right. I think we are all clear now. The one who has the question, are you okay? Was it Aduma? Are you okay?
I'm okay, thank you.
All right. Can we continue? Please try to
A
hold on for me. Let
child,
us finish with these questions so that we can go, okay? Mm-hmm.
A child 4 kg post cardiac surgery has a chest tube output of 50 mils in 1 hour. What is the nurse's priority action?
Okay.
C.
A.
What are we choosing? Someone said D. Someone just said C.
C.
Why are you choosing C?
Okay, so the child weighs 4 kg, and we have just learned that 5 to 10 mils per hour per kilogram per hour in the first hour might be indicative of cardiac tamponade or bleeding. So if you even calculate with the lower limit, it's 4 kg times 5 will give you 20. If you calculate with the upper limit, 4 kg times 10 is going to give you 40. And even for the normal range that we are saying is a red flag, the 150 mils per hour is still exceeding that. So it means that the child has a serious problem that needs to be attended to. So you notify the healthcare provider immediately to take action.
That is correct. Yeah, that is correct. I think it's perfectly explained. Yeah, that is correct. Okay, the next one.
Sir, please, but 40 times 10 will give us 40. 4 times 10,
What I say will give us what?
40.
And what's the output here, according to the question?
Okay, okay. Thank
So
you.
it's still normal, right?
Yeah.
Okay.
So it's always 10 times the child's weight.
It's 5 to 10. Okay.
5 to 10, not
5
10.
to 10. That is even when you search, it's like 5 to 10, but per standard, you see, like this like a typical English question. They will always give you something which is out of range. Okay. So what our sister said, the range is 5 to 10. And 5 to 10, even if you use the higher limit, which is 10, times the patient weight, which is 4, you still get 40. But what you are having here, according to the question, is 50, which is still even higher above the upper limit. So you
Okay,
see,
sir.
yeah, so they always give you what will be above expected.
Okay, thank you.
Okay.
Which action is contraindicated for a child with a chest tube? A. Monitoring drainage. B. Keeping system below chest level. C. Clamping routinely. D. Assessing hourly.
I told you about this, right?
C.
Yeah,
What's the
see.
answer?
C.
Because of what? Risk of what?
Tension pneumothorax.
Tension
Tension pneumothorax. Good. Good. Because of tension pneumothorax. That is fine. Our next question.
A child scheduled for cardiac catheterization has severe diaper rash. What should the nurse do? A. Proceed with procedure. B. Apply powder and continue. C. Notify the healthcare provider. D. Clean area and ignore. C. Notify the healthcare provider.
What are we choosing?
C.
Why C?
Because it's the rash can pose a risk for infection.
Good. Please, this one, even in adults, okay, and cardiac catheterization questions, whenever the insertion site, wherever uh, the healthcare provider chooses to insert his or her needle, please, if there are any rash or signs of infection there, you should prompt, even before the procedure, the healthcare provider should know, okay? And they also know, so they will not even do it because of risk of infection. You might just push in an infectious agent directly into the patient's vessels, and it will get to the heart. Lot of big issues, right? So yes, the answer is C. All right, I think this will be our last question. Then we can go.
Which child should the nurse assess first? A. Infant with constipation. B.
Prioritization. Mhm.
Child with patent ductus arteriosus and MEMA. C. Post-op child with increased chest tube drainage. D. Child with mild tachycardia.
C.
The answer is C.
The answer is A.
C. C.
E.
C.
E for
Okay.
cat.
Okay. Okay. I think that is right. You see, these questions are very easy. They are very easy, right? Like the ones on your dashboard too. They are all easy. And they easy.
They're only easy when you know.
Pediatric growth and development. Okay. We are going to look at major developmental domains on these 5 items and some other terms. Okay. So we're going to look at gross motor examples are like sitting, walking, running, and all of that. You know, when we talk about gross motor or gross motor skills, they are skills that normally involves using major like muscles. Okay, the muscles involved, you know, the muscles involved are huge, like using your whole arm. Okay, using your whole arm or your whole legs to do something. Okay, so you see, like walking. When you're walking, use your whole leg to walk. When you are sitting, your whole should I say your buttocks, right, and your torso sits on your buttocks, something like that. Okay, so it's like you have larger muscles involved, right? And when you are running too, you have your legs involved. Fine motor skills normally involves smaller muscles, okay, like your fingers. So you can look at these ones you have here. Okay, when you want to grasp something or you want to draw something, it's a fine motor skill, right? Because you use a smaller um, a smaller muscle, right? Like your hand or maybe your wrist or something. So that is one difference between the gross motor skills and fine motor skills, right? We're going to look at languages, what to expect, and the abnormalities in them, specific ages, words that they should be able to say, sentences that they should be able to make, and the abnormalities, and how they react with the environment and with, themselves, with others. Talking about the attachment, their play, the relationships. Okay, we're going to talk about them. Then cognitive wise, how they think and how they solve problems. So we're going to look at all these things. All right. Now I I have made it, I've tried to make it more simple, okay, in several ways. Some are in tables and some you can see as they have been listed here. So let us look at some age specific milestones. Okay. When we mention infant, this thing we've said it before here in life class. When we say infant, the age cutoff point for infant or the age range for infant is 0 to 12 months, right? So anyone within this range should be able to sit without support, especially in the 6th month. Okay, in the 6th month, if you have a baby or an infant, the infant should be able to sit without support by 6 months. Okay. The next one, crawls. He or she should be able to crawl within or by 9 months. Okay. After I'm going to tell you something about all these cutoff points. Right? Then, when it comes to walking, by 12 months, they should be able to walk. These are the standards. Okay. And by the 12 month, they should be able to say simple words like mama or make sounds similar to that. Okay. It's normal for them to have stranger anxiety. If they don't know you, they don't trust you. Okay, there's nothing you can do for them to cling to you. Okay, so you see them crying when someone um, tries to take them, okay, or pick them up. So stranger anxiety that is there, and some case when you send them to even new locations, they don't like it. They will cry, they'll be fussy until you take them out of that place. Everybody has how he or she deals with that, okay? And the kind of play they play, right, is solitary play, okay? Solitary play. So that one, what it means is that, they'll be doing their own thing. They will have independent play. I mean, even if you are there and they are playing, it looks like they've not even seen you. They are doing their own thing, okay? So they play alone in that sense. All right. So let me tell you something. One thing about the developmental stages is that even in real even in real case scenarios, pediatricians would always want to give case time. Okay. And I think I was searching for questions related to that, but I couldn't find it. But I was like, maybe I should tell you so that you can keep it in mind. It's always better for you to give them time. Someone will not sit. Okay, let's say, look at this one, sit without support. Some kids will not be able to do it in the 6th month, but they will do it in the 7th month. And that is okay. Okay, but on records, there is the standard. When your child does it, some of the kids will even do it in their 5th month. Okay, so most of the times, pediatricians will give time. Do we have pediatric nurses here? I know we have. Can I see them here? Or they are hiding? Okay, so you will see these things, okay? And look at the crawling. We can even attest to it, especially our mothers here, okay, or our sisters here. You can even attest to it that we even have some case they will not even crawl at all. Okay, they will keep on sitting, and what they will do is that they will be holding on things to try and get up. They will never try and crawl like how a lot of babies will crawl. All of a sudden you see that they are trying to just walk without crawling. And it's very common. I hope you can all attest to that, right?
Yes, please.
Yeah, so these I mean those things are also there which are normal. But on 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 paper or let's say on records, these are some of the cut-off age points. Yeah, but in pediatrics, we try to give first time, okay, to pick up things. So uh when you get a question, this is just a rough say, okay? I can't be precise because I don't have similar questions here. When you get a question and the question is like, let's say the mother is worried that, let me use an example we have here on the screen. The mother is worried that the child or the baby is not crawling, okay? at age 9 months, what will be an appropriate teaching, okay, by the nurse to this mother? If you get any option, then if you get any option like or any option that tries to tell the mother that you should give the baby time, that is correct. Okay. Most of the times there will be an option that will tell you that the baby is having a developmental delay and should see the pediatrician. It is wrong in this case. I mean, in this scenario that I've cited. Okay, so we have some of them, like if let's say a child is about 2 to I think is it 2 or 2 to 3 years or so. But let me even give you the highest point. If a child is, or let's say a toddler, you have a toddler of about 3 years. I think sometimes it's even 2 years. Yeah, let me say 2 years. Yes, 2 years. And the baby or the child cannot say mama. 2 years baby cannot say mama. That one, you know that the baby or the child has a developmental issue. Okay, just mama. At 2 years, every baby or every child should be able to say that. So those are some of the exceptions. Okay. All right. Now let's look at our right hand side here. So toddler age range is between 1 to 3 years. Right. Jane, your hand is up.
Yes. Please, I want to get this right, okay? Does it mean that with questions like that, if the child has migrated in terms of age, has migrated from being an infant to possibly a toddler, and you're expecting certain things to have happened or certain developmental milestones to have been reached, and the child hasn't reached, that is when you raise alarm or you refer the child to a pediatrician.
Yes.
But if, so for instance, if the child is still within the infant stage and the child hasn't walked, it is not a big deal. But then if they migrate on to the next stage and still you are not seeing any sign of improvement in that area, that's when you refer to a pediatrician.
Exactly. Exactly. And you see, like I said, like I told you, you have to give them time. When you send any 12-month-old baby to a pediatrician because you think the baby, I'm using that as an example, okay? Because you think the baby should be walking or the infant should be walking by that time, the pediatrician will be laughing at you in his or her mind. I mean, in his or her, yeah, something like that. Okay. I think most of us here can even attest to it. Not every child or not every baby will walk even for the first, I mean, up to 12 months. Not everybody will walk. Some will still need extra time so that they can walk. And that is okay. Okay. I know some will even work by 10 months, 11 months. Yes. Some will do their working perfectly. Some will do it on their 13th, 14th month. But let's say someone who, let's say a baby, an infant, okay, at age 12 and cannot hold on to objects and stand with support. Okay, that is like a cause for concern. You know that. That is a cause for concern. Because even if they are not walking, they should be able to stand or hold on to something and stand. Okay. But the walking itself sometimes it delays. So some of them you have extra time that you have to give. And when the questions come before you, you will see it. They will not give you that marginal they will not give you marginal figures. Okay. Yes, because it's always known among pediatricians that you have to give them some time, okay, for them to pick up their developmental milestones. Some of them will pick them early, some of them will fall within within the range. Some of them too will need some time. Okay. Yes, but we have boundaries. Like these examples I'm saying. Okay, 12 months you can't hold on to anything and stand. Okay. Um 13 months you can do that. Age 2 years you can't even say mama. Okay, and some other stuff. Okay. We look at most of them as we move on. And um I have a pool of questions. I mean, a pool of questions. I intentionally brought more than 20 questions for you on growth and development and all of this. Okay. So, I mean, we are going to do lots of studies before the questions come in. I reserve the questions for the last so that I can really test you whether you remember most of the things that we'll speak about. Okay. All right. Mr. Jane, are you okay? Can we continue? So, as a toddler, okay, a toddler should be able to walk independently. Okay, a toddler should be able to walk independently. So, and they should begin running. So, if let's say your baby is between 2 to 3 years, getting to the later stage or cutoff stage of a toddler, and the baby is not walking, that's a straight developmental delay. Okay, that is a straight. So, you see, even when they should be able to work independently, you see the age range for toddlers. So if by 12 months the baby is not able to walk, the baby has some time, okay? The baby has some time, sometimes even 1.5 years, okay? One and a half years is like 18 months. Sometimes even with 18 months, the patients will want to give some other time, okay? Some time. So they will be worried maybe after 2 years, getting to between 2 and 3 years, if the baby is not able to walk at all, then they will be considering a possible problem, right? So most of the times they give time. And the baby around this time should be able to use 2 to 3 word sentences. Okay. And they normally engage in parallel play. So toddlers and parallel play. Don't forget, right? Toddlers engage in parallel play. And this is what it means. Everybody will be doing his or her own thing. Okay, so let's say if they are in school, everybody will be having his or her own play without interacting with each other. Okay, everybody will be doing their own thing whilst they are even together. No one will they will not share toys, they will not do like there is nothing like a conjoined something happening. Everybody is doing his own. That you know how parallel lines are. They are lines that moves together, okay, in a similar direction, but
They don't meet.
they never meet. Okay, they never meet. So they will never come together to do anything, but everybody will be doing their own thing. And they are egocentric. Okay, they are very egocentric. When we say egocentric, I hope you understand. It's like they how should I even put it? It's like they want you to understand how they are. They think differently, and how they think they want you to think same. Like they consider what they think to be a standard for everyone.
Yeah, yeah, yeah.
Okay,
They want you to see.
come again.
No, I'm trying to say like they want you to see things like from their own point of view.
Yes, from their own perspective. Good. Okay, so look at the word ego. Okay, so they what they say is what they think to happen. Like they they are in their own world, right? So they are egocentric. They have egocentric behavior. If
But
they
yeah,
want, yeah,
does it mean that the egocentric, can we also say that they want you to please them? That is whatever they want to do. You
yes,
cannot stop them. But
yes, you cannot stop them. So let's say if they pick up your can of, let's say, powdered milk, and per them, okay, let's say per what they think, they want to pour everything on the floor. They want you to think it as a normal thing. They want you to just conform to it. Okay, you can give similar examples in different ways. And whenever you try to take it, that's why whenever they are doing, when they reach such age, they tend to do those things. I've, I've remembered, like, I mean, everybody has something to say about that, right? So they will be misbehaving. Should I say misbehavior? Even though it's normal to them, okay, in their own world, it's very normal. And when you try to stop them, they don't understand why you are stopping them, because in their own world, they are doing their normal thing. That's why when you try to stop them, they cry. Okay, they throw tantrums. They have temper tantrums. If you
They
don't
sleep
do
on
as
the
they want,
floor and be
yes, if you don't do as they want, they can even throw themselves into, even if you are close. I mean, they are closer to fire. They don't care. They can hit their head anywhere if you don't hold them well. All those temper tantrums. So it's normal within their age range. So let us take it. All right. Now, preschool. So between 3 to 5 years is preschool age. Okay, let's take note of that one to preschool age. So at preschool age, they should be able to hop, skip, and speak in full sentences. Okay, and the kind of play they play is associative play. Okay, associative play. They interact with each other. Okay, but they have no rules. Okay, even though, yeah, they interact with each other, but they have no playing rules. And they have their imaginative play increases, right, as they move on with their ages. Jane,
Yes, someone is complaining on the page that they can't find the link.
someone should help them, okay? Let us carry on. Right. Okay, so let us move on to the right hand side of the screen. Um, School age is between 6 to 12 years, right? Between 6 to 12 years is school age. So by this age, they should be able to have what? Improved coordination. Okay, improved coordination. Then there's logical thinking. I mean, their logical thinking develops, and they have cooperative play, teamwork, and the kind of play they have, it has rules. Okay, so let's say if you have, let's say, let me say 10 to 12 years. I mean, so you have two boys, okay, and they are either 10 or 12 years, and they are playing football. They will at least have a goal post, right? And they will have a rule that if you play and the ball enters into my goal post, you win. Sometimes it can be any kind of play, a puzzle play or something, anything at all. Okay, anything at all, but there should be rules, you know. So the kind of play that, or the kind of game that they play, they have rules because their thinking is what is increasing. All right. Then focus on achievement and peers. So as they grow, they focus on achievement and their own peers. So that is also with school age children. Let us look at the age range. Okay, it's very important. All right. All right, let's look at this one too. Adolescents from 12 to 18 years. Okay, from 12 to 18 years. And what we are saying is that over here, they're in their puberty age and growth is very, very rapid. All right, their thinking is very abstract. Identity formation is also pronounced here. And peer influence is very, very, very strong. Okay, peer influence is very, very strong. So over here, it's like the initiation period into adulthood. Okay, so that is how it is. All right. Let's look at some theoretical perspective of some of these psychologists. Okay, these psychologists. We go through all of these things. So I took my time to summarize almost all of them in a tabular form. Okay, so Piaget spoke about or formulated cognitive stages in pediatrics, right? Eric Erikson did for psychosocial development. Sigmund Freud did for psychosexual stages. So so let us look at this table here. So we have the first column, the second column here, where I'm shaking the mouse, okay, to be Piaget's cognitive theories, okay. Then Eric Erickson's psychosocial theories, then Sigmund Freud. This is psychosocial, this is psychosexual, okay. All right, so within 0 to 12 months, that's for infants, according to Piaget, the child should be able to what? Learn through sensors and movement, develop object permanence. Uh, when you join and you don't mute up, please, you disturb the class. Okay, so try and mute up when you join. All right. So infants, they learn through sensors. Okay, according to Piaget's cognitive theory, they learn through their senses and movements. Okay, and they develop object permanence. So I give an example here. Example: infant shakes a rattle or looks for hidden toy. Okay, so when you get questions and they're like, according to Piaget, or sometimes they not even quote the theory or where it's coming from. Which of the following activities is incongruent, okay, with an infant or maybe with a 9 month or 10 month old baby, okay, or maybe a 12 month old baby? They can give you that. So, according to Piaget, cognitive wise, the infant should be able to um, learn through senses and movements, develop object permanence. So this one example we can give. You can cite other examples too, okay? Like, infants shaking a rattle, okay, or they look for a hidden toy. When you have something and you hide it at your back, they'll be like they'll try and trace it at your back and see if they can find it. Okay, that kind of sense. All right. Then the next one for toddler between 1 to 3 is pre-operational. So this one they begin language and symbolic thinking, but it's egocentric. Okay, so it's like how we digested our first, our first or second flyer. I mean, screen. Okay, like this one, the stages we went through. So it's like they are all speaking about some of these things, right? Okay, so that is it. So an example here is when a toddler pretends a box is a car. Okay, they are in their own world. Okay, they do their own thing. Okay, all right. Then preschool. What is the age range or the age cutoff point for preschool?
3 to 5 years.
Between 3 to so between 3 to 6 years, yes. Okay, between three. So the 6 years is like starting for another. So let's say between 3 to 5. Okay, between 3 to 5. Six is like a start of a school age. So let's say between 3 to 5 years, which is preschool age, they should have imaginative thinking. Okay, I mean it should increase. Then magical thinking is common. Okay, so an example is that um, look at this one. Imaginary friends or believing cartoons are real. So their imaginations are very funny. Okay. When they watch cartoons, they think it's real. Okay. And I think sometimes should you I don't know about well, I'm not too sure. I want to anyone here who can confirm in relation to dreams, how do they perceive dreams? Since I've seen a question about that somewhere before, I just remember. Anyone here who can tell us where are our pediatricians?
Sir, please, can you repeat the question again?
How do they perceive dreams, like preschoolers? These people they are like we said, they are imaginative thinking, they are driven by emotions. Okay. Um well, maybe when I get it, maybe I'll share it. I saw a question somewhere. All right, let's carry on anyway.
Yeah,
So an example.
I
Mhm.
read somewhere that they believe death is reversible, like it's
Yes,
temporary.
yes, something like that. Yeah. So it's like everything they think about is like it's very funny, magical. Okay. Yeah. So just have that imaginative thinking aspect in your mind. Okay. So that when even similar questions are asked, you can be able to relate. Okay. Mhm. So yes, like you said, when it comes to death, they think it's reversible. When someone dies, the person can come back. Okay, the person is just sleeping. The person can come back. So when we say magical thinking, that's what it means, right? Okay. Now school age. So they think logically, okay, about concrete objects, and they understand conversation. Okay, they understand conversation. They understand that. So this is an example. They understand that shape um, changes do not change quantity. Okay, so this is just an example. Okay, so it's like they have understanding. That's what it's trying to say. When you're having a conversation with them, they understand whatever thing you are telling them. Okay. And let's look at adolescent age. You are saying formal, operational. What does that also mean? They are able to think abstractly and reason hypothetically. Okay, because from here they are into adulthood. So uh, they perform complex tasks like debates. Okay, they debate ethics of future career plans. So over here is okay. So normally pediatric questions will not even focus on the adolescent area that much. I'm not saying you can get, but it doesn't focus on it much. Okay, where the tricks are between infant and preschool, sometimes school age. So that is cognitive wise, right? Piaget cognitive theory. Now, when it comes to Eric Erickson's psychosocial theory, trust versus mistrust. So that is where the infant learns whether the caregiver is reliable. Okay. So at their earlier phase, when they are coming between, even I've seen like I think it's very interesting. Most of us can relate. Most of us here, right? Um, they don't trust anybody. Okay, don't trust anybody. That's why when you are or let's say when you happen to be the person very close to them until they enter into their toddler stage, they are glued to you. Okay. Yes, they don't easily trust people until they know whom to trust. Okay, so that is it. So an example is like baby cries and is comforted consistently. Okay. So when another person or someone whom the baby has not recognized picks him or her up, you see him or her crying. Right. The next one is autonomy versus shame and doubt. So they want independence and control. They insist on feeding or dressing self. When they get into, sometimes it depends, okay? Somewhere within 2 years, anywhere between one, it's possible. It's possible, it's a range. So between 1 to 3 years, let us try and at times give them their space, okay? Serve them with food and their spoon, let them do their own thing. They will throw half away and they will eat only a penny. But that is okay. All right. And whenever you try, even when they are throwing it away, when you are trying to, I mean, take the spoon from them and help them and feed them, they wouldn't need your help. And they will cry when you try to come in or when you try to come into their way. Okay. They just want to be independent and do their own thing. So even if it's food, they want you to give them the spoon for them to eat and throw the food. I mean, throw most part of the food away. They don't want you to help them. So that's how it is. Preschool, that's initiative versus guilt. So they enjoy exploring and initiating activities. Example is like they plan games and ask many questions. Okay, that is okay between 3 to 5 year olds. Then school age, that is from 6 years, right? School age is industry versus inferiority. They develop sense of achievement through school and as example, proud of grace and or sports success. Okay. So these are the people who who even try to do homework stuffs and all of that when they are even hospitalized. Okay. Yeah, they want to do all of those things and they want to keep up. Okay. The last one, the identity versus role for adolescents. So they develop personal identity and values. Example explores. So this one with the adolescent aspect, they are very easy to pick them up. So I wouldn't even waste much time there. Now the last aspect is the sigmoid fraud, right? Psychosexual theory. So the first is the oral. Okay, so pleasure centered on mouth activities. Anything they get hold of, they want to put it in their mouth. Anything they get hold of between 1 to 3. Yeah, so it's like all those developmental milestones. It's like these people. It's like these people theories combined, right? That is how it looks like. Okay, these psychologist theories combined. So um the sucking is there at the oral phase, breastfeeding, putting toys in their mouth. Yes, they do that a lot. The next one is the toddler stage, which is the anal stage. Okay, it focuses on bowel and bladder control. So this is where you do toilet training. Keep it in mind. Toilet training is within the toddler stage. Okay, so anyone who is 2 year, or yes, any child who is 2 year old, any 2 year old baby or child should should be taught potty training. Okay, should have potty training. It's very, very important. So by the time this baby gets over 3 years into the next stage, the baby should be able to um should be able to pass potty training without any issue. Okay, very important. So let's say if you have a 4 year old baby, or let's say a 5 year old child, and this person is still in diapers, okay, like this person is still wearing diapers and can't control the bowel and all of that, can tell you when he or she wants to pee, or maybe pee or poo. Let me use pee or poo. That would be very simple. Then that is an issue. Okay. 4 5 year old child, and the child cannot tell you when he or she feels to pee or poo. That is a problem. That's a developmental delay. Okay. So those are some of the things we are talking about. The next one is the phallic stage for preschool. So awareness of body differences and curiosity about genitals, right? So this is where if you don't take care, all right, sometimes you hear of you know, especially when you are in an environment. I don't want to use some words. I don't want to use stubborn. I don't want to say like, because they are, they are sometimes they are explore. All right, when they see a female, they want to know that, or they want to try and see whether what they have is the same as what any female has. Okay, they try to be curious about all of these things. Okay, and even sometimes some of them are very curious. Sometimes even among their own um sex, okay, sex group, they just want to know how it is for even their friends. So that's the phallic stage. All right. The latency stage for school age, that one over here we are saying sexual interests are less prominent. Okay, so they focus on learning and friendships. Example, they enjoy same-sex peer groups and hobbies, right? So this is actually okay. So for the sigmoid fraud psychosexual theory, at the adolescent stage, that is where most of the problems are. Okay, so um, yeah, genital. It does the genital phase. they mature sexually. Okay. And that's where you see sexual relationships emerging. Okay. So they begin to have interest in romantic relationships. And that is where most of them tend to become stubborn. For adolescents, let me say stubborn. Okay. Yeah. So that is it. All summed up and wrapped up on this table. Any question or any addition? Okay. All right. Now, there's another table here. I intentionally brought this table too. Okay. So this one's help spell out some of the specific things that normally go on. It's more of a breakdown than the previous one we did. Okay. Some of the things they can do, I mean, per age groups and what they can do. Okay. All right. So the first one here, within age 1 month, when it comes to gross motor, the baby should be able to lift the head up. Okay, sorry. Yes, lift the head up when you turn them when they are in a prone position. You all know prone position, right? Like when their face is facing the ground or the bed on which they are lying. They should be able to lift the head. Okay. Now, when it comes to fine motor, hands remain tightly fisted because they are very young and small. Okay, they cry when they are upset. They gaze at their parents' face. So they'll be staring, especially when they are breastfeeding. They'll stare a lot, and that's what they do best. Between 2 to 3 months, they should be able to gain head control. Okay, they should be able to gain head control when held upright. They should be able to hold rattle briefly when placed in their hand. So even though it will fall, but they should be able to hold it for some time. And I think this one is common, right? The next one, they should be able to, when it comes to languages, between 2 to 3, they should be able to make cooing sounds, right? And social and um, cognitive wise, they are they smile responsively, okay, and they recognize familiar faces. Okay, so they'll be spotting faces. Between 4 to 5 months, they should be able to roll front to back and back to front. Sit with support. Okay. Fine motor. So this one, when you get time, I know it's a lot. You take your time and you digest it. It's a lot for you to. Most of us, because we have experience, we can relate. But um, if we can't try and at least get time and go through this, okay, it will help a lot. Okay. Um, so they can sit between 6 to 9 months. They can sit without support. See, like we said already, um, begins crawling, may pull to stand. Okay. It, they can transfer objects hand to hand. Okay. So you can get a next question. This one, for every section, you can get a question on it. For every box over here. Every box over here is a question in this, guys. Okay. But I know it takes time for you to, just pick it up. Look at this one. Between 12 to 15 months, they should be able to work independently, and they should what? they should be able to creep upstairs. Okay, they should be able to creep upstairs. All right. Then they can build tower of 2 blocks. They can use cap with little spelling. Okay, whether a cup or anything that they drink from, whether a bottle, they can find um their way to their mouth and do as they want to do with it. Okay. And they should be able to say between 5 to 10 words. They imitate their parents and they show affection. Between 15 to 18, they run clumsily. Okay. They run without formula. They don't even watch the ground, whether there is something there or not. Even even before they start running, when your leg is on their way, they it's as if they've seen it and they're intentionally doing it. They will run without watching your leg and they will actually trip. Okay. So that is what normally happens. And they tend to climb furniture. So if you have a kid around this age group and they are trying to climb furnitures and trying to climb things, it's normal. Okay. Okay, so they scribble spontaneously and they use a spoon well. If you haven't tried, give them spoon and see. Even though they are going to throw some away, but they are going to eat some too. Okay. Yeah, vocabulary increases to 10 to 25 words. Okay, so it's a range between 15 to 18. So by 18 months, and if by 18 months, um, this child hasn't been able to reach about 25 words, still the pediatrician will not be concerned. If there is still some kind of words that the child is able to say and has not necessarily reached 25, they will still give the baby or the child time. Okay? Because if there is a delay, then it means there will be no words at all, almost no words at all, or maybe one or something less than this range. So that is it. Then temper tantrums may occur and they explore their environment too. So that's all what they do. 18 to 24 months, they jump with both feet. Okay, they jump with both feet. They can walk upstairs with help. And look at this one. To those of you who have seen questions on tower building, right? So they are able to, by 2 years, they are able to build between 4 to 6 block tower. All right, like those toys that they arrange. And they can be able to turn pages of books. Okay, they can be able to turn pages of books. When you give this task to a 15-year-old baby, you are going to regret. Okay, like turning pages of book. When you give this thing to a 15-month-old baby, you are going to regret that you give the book to that baby. Okay, he or she will always structure it for you. Then the next one, they are able to combine two word phrases, right? Parallel play because they fall within the toddler age and increasing dependence. Okay, I think the rest over here we can catch up, right? So that is what we have. If you have any question here, you can let us know before we carry on. Any question or any addition? Okay. Now let's look at something. Red flags. Okay. Red flags. So the first one, if your child is not sitting by 9 months, then it's a cause for concern. Okay, it's a cause for concern. No working by 18 months. So you remember when we were doing the toddler, the infant stage, we said by 12 months they should be able to walk. Did you see that? But where it becomes a red flag, you see, from 18 months onwards, if the child is not able to walk, then it means it's been delayed. So we are not saying if the child is not being able to walk by 12 months, even though the normal cutoff age is up to 12 months. But we are not concerned. We we are going to 12 plus what will give you 18, 6 months, right? So it means we are even giving what? We are even giving 6 additional months on top, okay, to the baby, to give the baby more chance or more room. So for babies and development, you give them chances. And look at the words too. Okay, if remember we said up to 12, okay, up to 12 or 15 months, they should be able to use some words and sentences. Over here, we are not worried when they are 20 months and they are not saying anything, we are not worried. But the cutoff for the red flag is 2 years and no worse. Then that is going to be a big thing or a big deal. Okay. Then loss of previously acquired skills. So let's say the baby learned how to do something. Okay, let's say how to climb. And now, your usual furniture. And now the baby is not, or the child is not able to climb that same furniture he or she was climbing before. Okay. Baby was able to say mama. And now cannot say mama or something. Okay. That is a red flag. Okay. Nursing implication. So we have to monitor growth charts regularly. Okay. Assess milestone achievements. Educate parents on parents on expectations. Okay. Then promote age appropriate play. Promote age appropriate play. It's also very important. Then the last one here is identify early signs of delay. Some people are able to identify it earlier, okay, and they get help, okay. Yeah, they get help. If you have any question here, you can ask before we carry on. Any question or contribution? But are we here? I hope you are not sleeping, right?
No,
Sila,
sir, we're here.
No,
Yeah, no.
please.
it's like
We are
it's like
following,
I
sir.
am doing all the talking and everybody is quiet. Don't worry.
We are killing. We are listening.
You have about 30 questions waiting for you, and everybody will talk.
We are killing
Okay.
listening.
Okay. Okay, Sila.
Yes, but yeah, please, I want to know at what age can a healthcare provider, seek for assent from a child, not consent. I know consent is from 18 years and above, but assent. I've been seeing questions like that.
I don't understand your question. Can you please make me understand?
Yeah, I'm saying at what age can
Mhm.
a healthcare provider seek or ask for assent, like willingness from a child to provide care to? I've been seeing questions like that.
To perform a procedure.
Yes, please.
Okay. Okay. Let me try and see and understand. Sorry, and answer you. If that will answer your question, okay. If not, you can come again and maybe someone can help you. So if I understand your question, when according to like regulations, if you are below 18 years, you are considered a minor, right? And you can't take some straight decisions on your own health without the consent of your parents, right? But even with that, we have exemptions. And the exemptions, everybody should also know. Okay, we have exemptions. So let me give you something. Let's say one exemption is you have um, a 14-year-old female coming to the hospital on account of sexually transmitted disease. Anything that has to, or any treatment that has to do with sexually transmitted disease, you, the healthcare provider, you can provide without breaching any state or, I mean, without breaching any state rule. Okay, so that is one. Sexual, like STIs are one. Then I think pregnancy too is one. Even when you have a 12-year-old baby, so we call them um, you know, but if they are married too, okay. So we have cases where they also become emancipated minors. Okay, they are minors though, but they have been freed from parental consent because of the circumstances they find themselves in. So when, let's say, even if you have a 12-year-old child, and that child is, come again,
Okay.
yo, when you have a 12-year-old child and the child is pregnant, when that child is pregnant, the child has authority, 100% authority over her health without any consent. Okay. So STI, pregnancy, then when we have cases where I think they can be freed if let's say parents are alcoholics or they are abusive or something, per court order, the case can be emancipated and they will have their own will, okay, without seeking consent to do anything from the parent. So that is also there. I don't know whether it's in line with your question or I'm saying something else different from what you asked.
Yes, please, I'm fine. But what I saw um reading the rationale was that the parent of a child at the age of let's say 7 or 8 will give consent, but the child should give like assent, like willingness.
Yeah. So the word you are even saying, it's new to me. Those of us here who understands English, can you spell it for me?
Please, I want to come in.
ASSENT.
Yeah,
Assent.
Okay.
ASSENT.
Yeah,
I
that's
think
the word.
But I know.
Oh, okay, accent. Okay.
Yeah.
Oh, okay. So it's like consent. Another word for consent. Oh, okay.
Yes.
Yeah, so I wasn't hearing the word well. Okay. Accent. Okay. Yeah, so I mean, I think it is in line with what I'm saying. If you have any child from 17 years and below, anything that the child will have to perform or will have to go in for, if it's in it, like, please, I don't want to even limit it to only healthcare. Okay, let me give you one common example over here around my area here. What I've noticed is that young kids like tattoos. A minor cannot go to a tattoo, I mean, shop or a tattoo place and just do those procedures. I'm sure it's not done unless they have a parental consent. Okay, so it's like hospital procedures and those things. So whether assent or consent, I think it's in the same line. So lots of things the kid cannot, and most of the times it doesn't necessarily mean the parent should be there. Okay, sometimes consent can be given on phone and verified if it's true. Okay, if it's written to, then that is fine. But I mean, every place will have their own protocol. But the thing is, the minor can never do anything in like any procedure on him or her without parental consent if he or she is a minor. Okay, who wanted to come in to add up?
But can I come in small, please?
Okay.
In our situation here in the UK, there's a third category where if they say the child is about 16, 15, and they prove that they understand what you're communicating to them, then they don't need consent. We have that third category. I'm not sure how it is in America. Thank you.
Okay, thank you too for adding up. The one who has a question, are you okay? Or you still need
Yeah,
more?
please.
Okay,
Let me also come in.
all right.
I think what she was asking was like maybe you want to perform a procedure on a patient. Let's say mostly you try to ask for permission from the patient that, oh, I want to do this thing for you, explain procedure to the person before going to do. I don't know if that is what the lady is trying to find out. At what
Yeah.
age do you have to seek permission from the patient for her to give you the go ahead or asking to do that?
It's 18. It's 18 going. So if you're a minor, you seek permission from the mother or the parent. Okay.
Like for
Because
instance, maybe you want
uh-huh.
to go and do IVI. Then
To go and do what?
she wants, let's say maybe to go and pass IV line,
Okay.
or you want to go and set IV line for a patient. Maybe the person is 8 years.
Mm-hmm.
She is trying to like find out. Maybe you have to ask permission from the child. And at that moment, is it that if the child says no, do you have to stop or you have to still continue? I don't know if I'm trying to get what the person wanted to find out.
Hello. Is it part of your question? The one who was asking the question?
But yeah, no,
Sila.
my question is,
Then make your question more more focal. Like it's like you've opened it and it's like maybe your question is different from what you are saying. Try and let us understand
Bozia,
so that we can help you. Let her
okay,
come
so
again.
but yeah, my
Let her,
question is that,
mm-hmm,
before you do any procedure, there must be
mm-hmm,
consent, right?
mm-hmm,
So when the person you are, having the procedure on is less than 18 years, the
mm-hmm.
parents come in to, give consent, isn't it?
Yes, that is it, correct.
Yeah. So when the patient is less than 18 years, the parents give consent, but the child must be willing. The
Oh,
child
okay.
must be willing
Uh-huh. Yes.
to, have the
So the child
procedure
must
done.
cooperate.
Exactly. So at what age, like, does a child, give that willingness? So I had the question wrong, and later, like when I was reading the rationale, I saw that it was less than 8 years.
It's from
Rather,
7 up.
7 to 8.
Yeah, from 7. 7 plus.
you said less than 7 years or more than
Like
7 years.
7 to 8. Seven
Uh-huh.
to eight was the
Uh-huh.
answer.
Okay.
Yeah.
And that is the age for school going age, right?
Yeah.
Yeah. So you see now your question is clear. Now let me show you something. Um, hey, I I took away my slide, right? Let me see something. So let's just look at this one. and see if maybe it agrees with it. 7 to 8 is like a school going age, right? Isn't
Yes.
it?
Yeah, it's cool.
Now look at this one. They think logically, right? Look at Piaget's cognitive thinking. So with this one, I think it's in line with this. So I now understand your question. Okay. Look at this one. Their thinking is concrete. They think logical about concrete things. And they understand conversation. Okay. Look at this one. They understand conversation. If it happened to be anyone here, we would force the person. Or maybe try to lure the person, even if not force, like to lure the person or maybe divert the person's attention and give it. But over here, from the school age, um, from the school age point, okay, or the school age range, you will have to reason with the patient, okay, or with the kid because they understand conversation. So I think it's in line with this one. I now get you, okay. And remember, it is around this age that let's say if the child is let's say you're going to perform general assessment, auscultation, and the rest, okay, and the patient is afraid of stethoscope, you can that is where you can give the stethoscope to the child to handle it and see how it feels, right? Because they understand conversations, you can reason with them, okay, just to help them cooperate. So yes, I understand you now. So that is the school age, okay? That is the
Okay.
school age, which is between what age to what age?
6 to 12 years.
The school age is between
6
what
to
age?
12. 6 to
6 to
12.
12.
Yeah.
Yes.
Thank you so
So
much.
that is it. You are welcome. Mhm. Now, anyone who wants to say something else? Okay. All right. Any other question? If not, then let us look at I think we've done this one too. Um Developmental stages. So let's say when we talk about development itself, it follows a particular pattern, okay? Cephalocaudal, if you've heard it before, cephalocaudal and proximodistal. All right. Um Talking about cephalocaudal, like you see here, from head to toe, right? So cephalo is your head and caudal is your tail. And the other one is what? From the center of your body to the outer part or outside of your body. You'll look at it and you'll understand. Okay. All right. So talking about cephalocaudal development, that's set to toe. So we are saying this one, I listed everything here so that we can digest it well and see. So the term cephalocaudal means development progresses from head downwards. Okay. Downward towards the feet. So look at how it happens. You see infants first gaining control over their head and neck first. Okay. When you give birth or when you have a newborn, as part of or with when you're tracing the way they develop or the way they grow, you first gain control over their head and neck first. Then they gain control over their what? Their shoulders and trunk. Okay. That is where they're able to they're able to sit. Okay. That's where they will be able to sit around this stage. Then finally they gain control of the legs and feet. That is where they will be able to walk and run. So you see how the development is. It starts from how to be able to hold the head and neck up. Then to come to the shoulders and trunk. That is where sitting will come in. Okay. The trunk, so that when they sit, they will not fall on their back and all of that. Okay. Because most of the times their head is, when they're in the first phase like this, their head is heavy for them and their neck is very weak. Right. Then finally, they will be able to use their legs and feet. That is where they'll be running and you'll be chasing them. Okay, so when we talk about cephalocaudal development, that is what we are trying to explain. Okay, and we are saying this explains why babies can hold up their head before sitting, sit before standing, stand before walking. That is perfectly explained here. Okay, let's look at some examples. A newborn can move the eyes and mouth before controlling the leg movement. Head control develops before trunk stability. An infant learns to sit before learning to walk. This is just to add up to what we just said. And what's the clinical importance of all of this? We, nurses and healthcare providers, assess whether motor development is occurring in the expected sequence. Okay. So an example, we've said this before, already, but look at this one. A 6-month-old should have a good head control. 6 months should have a very good head control, because around this time we expect them to sit already, okay, or to begin sitting, something like that. Lack of head control may suggest developmental delay or neuromuscular problems. So that is where the screenings will come in. And the second one is what? Proximodistal development. When we talk about proximodistal development, what does it mean? Proximal is something that is away from you, right? Sorry, that is closer to you, proximal. Distal is something that is away from you, rather. So proximodistal development, that is something that is more closer to your central parts of your body, to something that is far away from your body. All right, so it says the term proximodistal means development progresses from the center of the body towards the extremities. So example is child gain control of the trunk and shoulders first. Okay, then arm next. You see, after the child is able to sit, okay, getting control of the trunk and the shoulders first by maybe getting control of how to sit. Then the arms will follow. Okay, the arms will follow next for them to be able to move their arms like precisely. Then their hands and feet. So this one is like a gross motor. Normally gross motor comes before fine motor actions. So moving the whole arm is like a gross motor activity or motor action. But using the hands and fingers, okay, using the hands and fingers at last, that is the fine motor activities. Okay. This point, we are saying large muscle control develops before fine motor control. So like I demonstrated over here. Okay, this is like an example of a gross motor development. This is also a gross motor development. Then this one is a fine motor development. If you have any question here, you can ask. So this one too, we have an example here. Like an infant can wave the whole arm before picking up a small object. They can easily wave first before trying to learn to pick up small objects on the floor or on any surface, right? So another one, a toddler can grasp objects with the palm before using pincer grasp. We know pincer grasp, like trying to use that is your index finger and your thumb. Okay, your index finger and your thumb, something like that, like a pincers. Those pincer devices. Some of us here, you know, right? Okay, so that is it. Okay, the infant will be able to move the whole arm before picking up small objects. Toddler can grasp objects with the palm before using a pincer grasp. Children scribble before they can write neatly. This one, everybody is aware. Before they will be able to write correct and neat sentences or even letters, they will have to do the scribbling, waste tons of sheets, right? Pencils, crayon, whichever writing material they can use. Okay, so they scribble first before later the fine motor action comes, right? Where they can write it. Any question at this time? So fine motor example, like fine motor activities. With the example we have over here, baby develops shoulder control to arm movements, hand grabs, finger coordination. Okay, so this gradual progression allows skills like um, buttoning of clothes. So with time, this child will be able to do this. This child will be able to use any utensil, okay, put before him or her. Then this child will be able to write. Any question? Any question on this one? If not,